everyone. Welcome back, and thank you for sticking to time. And I'm just going to say, how good's the graphic, by the way? That was our favourite thing when we were approving, the different graphics for the event. Now, I'm sure we've got a few more people still wandering in. I hope you had enough coffee, enough to eat. We're energised and ready to start our next session, which is one of, I think, our clinicians' favourite times of the week is when they come together and do their MDTs. So I'd like to welcome Michael and Z Tingley onto the stage and to chair this next session, which is our MDT panel. So on we go.
Thank you very much, Annette. It's my pleasure to co-host this session with Professor Z Tingley from the Austin. She's a nuclear medicine physician like myself. We were in the same training cohort, I think, all the way through.
Medical school.
We go back a long way.
That's right.
And Z Ting's also the incoming president of the AANMS, which is the Australasian Association of Nuclear Medicine Specialists. So everyone, don't forget to tweet. It's hashtag ProsTIC22, but I've got a rumour, so don't tweet the rumour. Declan, that's for you, no tweeting, it's only a rumour. It's only a rumour, but you heard it first at ProsTIC22. PSMA PET-CT will be funded in Australia from, does anyone know? July the 1st. And for our American colleagues, I think the funding, it'll be $1,400 Australian dollars for a PSMA PET, which is about 1,050 US dollars. We won't ask them how much it costs in UCSF.
That's right. That's right.
So the structure of the session today, it's only a rumour. Please don't spread the rumour. Not officially announced yet. The structure of the session today is going to be pretty practical, hands-on. We're going to show you cases, and we've got a very illustrious panel that I'll introduce briefly. We have Dr. James Buteau, who's a nuclear medicine physician from Canada, who's been at Peter Mac for a couple of years now, doing a PhD in PSMA theranostics. He's going to be hands-on, presenting the cases live. Next to James, we have Shankar Siva, who needs no introduction after session one. And next to Shankar, we have Dr. Louise Kostos. Louise is a medical oncologist who's also doing a PSMA theranostic PhD, which is fantastic. So Shankar, I think we're missing a radiation oncology PhD student. That's your job for the next week. And next to Louise, we have Declan Murphy. Declan doesn't need an introduction. He's the head of the GU Oncology Service at Peter Mac, a urologist. Declan has more Twitter followers than everyone in Peter Mac combined.
Wow.
Yep, like over 5,000, something crazy number.
Yeah, 9,000.
Yeah. Everyone's listened to his Noosa talk on the beach. So with that, we might fire away with case number one. I'll hand over to Z Ting.
Fantastic. Thanks, Michael, for that. So we will just push on with the cases. And if, Michael, you can advance those slides, would be great. Thanks. Good. Okay, so case one is actually a case of a 58-year-old man with a PSA of 16 who had a Gleason 9 biopsy-proven cancer, and he was referred for consideration of curative intent treatment. And an external staging PSMA PET was done, and it came in with the report of bilateral pelvic nodal metastases, left axillary metastases, bone metastases in the right iliac bone and L3, and multiple lung metastases. This was accompanied by some safe screens that were sent in with the report. So the question for the MDT panel, actually, firstly, is what would you guys do as the referring clinicians of this patient, and you got this report? What would your first step be? I guess we'll start with Shankar. Or Declan, actually. We'll start with Declan.
Yeah, so we showed in the PRO-PSMA trial that the use of PSMA PET-CT provided greater accuracy compared to conventional imaging, and that's been well borne out in other data. However, it's still very important that we scrutinize these images. There is variability in the quality of PSMA PET-CT, although, again, within PRO-PSMA, We did do central review from the 10 sites and did show the concordance was very high, especially compared to MRI, for example. But nonetheless, it's still very important to review these images. So that's the first point I think I'd make, Ting, is that we do like to review all these images ourselves, because it's a big call. Does this patient have distant metastatic disease? Does he have high volume distant metastatic disease? It's very important that we have confidence in the findings before we make a management recommendation.
Excellent. Okay, well, we might actually move on to the next slide and actually get James to present the case for us.
All right, thank you. So we did get the images imported and had a look. You can see that this is the MIP to the right, and it's quite saturated. So I think that if we have a look down here, you do see the prostate cancer very highly avid, just below the bladder. There is quite a bit of noise, as you'd expect for PSMA PET, but it's very, very saturated. So usually Peter Mac will window it with 15 upper window, so it looks a little bit more like this when you're interpreting, and you have a little bit less of that noise that isn't actually significant. And if we have a look at those screen caps, you actually just had a lot of noise down here in the lower lobes of the lungs. So it wasn't actually, there weren't actually metastases, nothing on CT either. And you just look at the PET image itself, it doesn't look like there's anything that actually stands out. Same for the nodes down here in the pelvis. So again, it does look a little bit more alarming, but then when you look at it in a more appropriate window, there isn't anything of suspicious, and same for those bone metastases. So windowing is quite important. It does change how you interpret. It's okay to change it, so you can adjust the windowing. As you see, we say 15, so anything above 15 is very red or very dark. Here, anything that was above 4 had that same appearance, so it's good to have it more around 0 to 15. You can change it just to increase sensitivity while you're reporting, so it's good to change that windowing, especially if you're looking for little pelvic nodes and you just want to have a higher sensitivity.
Thanks for describing that and the importance of windowing. So my question for the panel would actually be, does every PSMA PET that you get from an external site or even internally need to be presented at a MDT? Any one of you?
Yeah, I think at the moment, definitely yes, because outside of clinical trials, we're doing PSMA PET scans either to aid in diagnosis or to assess whether a patient's suitable for radionuclide therapy. And I think those are decisions that really need to be made in the multidisciplinary setting. But this case also really highlights the danger of not doing an expert review of the PSMA PET scan, because obviously in centres that aren't used to reporting PSMA PET scans, there can be variability in the quality of the reports. And also emphasises the importance of doing PSMA PET scans in the appropriate setting. In this case, it was appropriate because the patient had high-risk disease. I think it was grade group 5, so according to the ProPSMA trial, it's appropriate. But for example, in a patient with lower risk disease, having this particular PSMA PET report could have caused them a lot of danger, particularly if it wasn't reviewed in an MDT.
Fantastic.
We might move on to case 2. 62-year-old man, PSA of 6, MRI shows a PIRADS 4 lesion with no pelvic nodes. Biopsy confirms a Gleason grade group 3 plus 4 equals 7, grade group 2 prostate cancer, and he is referred for consideration of curative intent treatment, perhaps surgery, and a PSMA PET CT was done. James, do you want to show us what it shows?
Yes, so you can see the PSMA PET right here. The prostate cancer, left mid prostate, highly avid, SUV max of 14. And effectively, there's nothing in the pelvis. You don't see any node metastases as you carefully scroll through. You can increase the windowing just to have a little bit more sensitivity, but nothing is suspicious. The only finding is up here in the retroperitoneum. So you do have one focus here with the SUV max of 6. And a little bit of a nodular, a little bit elongated soft tissue finding, 0.5 millimeters by about 1.2 centimeters. Otherwise, no metastases other than this finding.
Yeah, and that little nodule on the outside PET report was reported as a retroperitoneal nodal metastasis. So that actually makes it M1A disease because it's outside the pelvis. What do you think about that, Declan?
Well, this is Tom's talk earlier about appropriate criteria is very, very important because, of course, this patient shouldn't have had a PSMA PET-CT in the first place. It's like looking for directions in Ireland. If you drive up to a crossroads and ask a farmer, how do I get to Tipperary? And there's, well, I wouldn't start from here if I were you. And that's exactly the case here. We shouldn't start from here. This is favourable intermediate risk prostate cancer. And actually, EAU, NCCN guidelines don't recommend any form of cross-sectional imaging here. So that's very important that when we consider an indication for a PET scan, we make sure that we're following some sort of appropriate criteria. And look, these are expensive. When you made the announcement about funding, the loudest yelps in the audience was from the chief executive. Did you notice? She wears the cost of all these thousands of scans. And so it's still very important that we have some sort of correct criteria. And I think the criteria are going to say intermediate and high risk, Michael, if I recall from the expert advice that we were given. So that was quite generous. So in fact, this sort of patient will be able to get a funded PSMA PET-CT, but I think it's very important that we clinicians recognise there's no data to support the use of an expensive scan like this in this sort of patient who in actual fact guidelines don't recommend any form of cross-sectional imaging. It only leads to confusion and delay. And
what do you think about this para-aortic node?
I'm not looking at it. It should have never been done. It's crack on. This man should have surgery or radiotherapy, and I will unsee it.
You want to unsee it, James? Yeah. What do you think about the para-aortic node?
Well, you do see up in the cervico-thoracic junction. You also see some other spots where you do expect to see some ganglia. And when you come back to that node, it is a little prominent. You do have, however, you have one on the other side, and it is a typical location where you do find these celiac ganglia. So it wouldn't be of any concern. I'd consider it benign, and this patient does not have any metastatic disease.
Yeah, so it's actually physiologic ganglion uptake. It's not actually a lymph node, and this was a little bit of a trap early on. We might go back to the slides. When we started doing PSMA PET, we saw some physiologic uptake in sites that we just don't see with other tracers, and a classic trap are these ganglions that do have PSMA uptake. Here's some histopathology of ganglion. This was first described by German groups as well. Cervical, celiac, sacral ganglia. The key is on the CT, they're linear rather than round, and they're often bilateral, as we saw. So it's really important to be aware of the normal distribution of PSMA PET, and all too often we see new centres starting PSMA PET with inexperienced reporters that just kind of learn as they're going along. If you come here to learn how to do PSMA PET, you really need to do a little bit of literature review, reading, spend a few weeks at a centre doing high volume PSMA PET, go to a course like this, upskill, because we don't want you reporting normal findings as physiologic, or as pathologic rather. And as Tom Hope alluded earlier, we do want to really improve the quality of PSMA PET-CT reporting around Australia, and we're now trying to do systematic reports using a template. We're currently using the ePSMA template at Peter Mac. It means everyone's using the same criteria, makes the things easy for our referrers to find, for the audience, go off and have a read of this EANM PSMA position paper. It's really quite handy, helps us all report in the same way. James, do you want to add anything else about standardised reporting and teaching and templates?
No, I think it's just good I think clinicians are watching, and they do use this information, even what could seem seamlessly unimportant, like what kind of tracer was used, what dose. It can have implications, for example, for the referrals to any research projects. They do pay attention. They do expect a certain quality. So I think it's good to keep that in mind. It's the only idea they have of the case.
And looking on, earlier George showed a couple of reports that were quite drastically different, and making it in a way that's easy for the clinician to actually understand without spending 15 minutes on it. That would be, I'm sure you'd appreciate that and saves your time.
I guess, so, I don't know, Shanka, do you have any thoughts about?
I think from a clinician point of view, that as Declan had mentioned, you don't want to steer away this patient from having potentially curative local therapy for their prostate cancer. But even for myself, I've been saved a few times by nuclear medicine colleagues who've reported what has been uptake in sacral ganglia or celiac ganglia, which are really and ask. And the question is, can I give SABR to these oligometastatic nodal disease? And clearly, I shouldn't be because they're not actually nodes, but they can be reported externally, and you can be led down the wrong pathway.
Great. Okay, we might move on to the next case then, which is that of a 53-year-old who presented in 2019 with metastatic prostate cancer with a grade group 5 Gleason 10 cancer, and multiple lines of treatment had been given, including ADT, docetaxel, ABI, and PRED. And a restaging PSMA PET was requested upon disease progression in a clinical trial. And of notice that a COVID vaccination was given in the right arm 10 days prior to this scan.
So this is the PSMA PET. You can see that the patient has predominantly osseous metastases. You can see some here in the scapula, going down into the spine, here in L5 in the sacrum, and some local recurrence, also some local disease in the prostate bed. And you do have these nodes right here. So in the right axilla, they're quite small. They have very intense uptake though. So SUV max are almost 17, probably just a millimeter or two. So the question is, and the injection was on the left side, so it wasn't an explanation for that. So are there any thoughts about if this is actually metastatic disease? Could it be related to COVID?
Yeah, I think this is really timely because ATAGI, which for our international guests is the Australian immunisation group that creates our vaccine guidelines, they just released another recommendation last week that certain patient groups should go ahead and have a fourth dose for winter. So we are going to be seeing imaging changes quite soon when patients start having that fourth vaccine dose. I remember last year when the COVID vaccines first came out, there were concerns with women having mammograms because of axillary lymphadenopathy. And I certainly saw changes in my patients with FDG PETs and even dotatate PET scans as well. But I haven't actually seen any changes on a PSMA PET scan that's been attributed to just reactive changes. And I think...
Can I just pause you, Louise? Because we want to take a vote while you're talking.
Yes.
Just voting's going to take 20, 30 seconds. We want to vote on this question. If everyone can open their app.
Right.
And the question is, do you think these nodes are benign due to COVID and you don't need to do anything? Would you report them as equivocal? I don't know. Maybe you should biopsy them. Or are they definitely just malignant because they're PSMA avid, and after all, it's prostate-specific membrane antigen? So interested in people's thoughts, and I was sorry to interrupt you, Louise. You can continue.
No, that's all right. So I think we heard very nicely this morning about PSMA expression, and it is quite specific to prostate cancer. There is uptake in other cancers, as we heard, in some normal tissues like salivary glands, but it really isn't expressed in normal lymph nodes. So my opinion would be that it's malignant, particularly looking at that SUV, which was quite high at 17. You could see that lymph node was quite hot on the PET scan.
You're in the minority. Only 7.4% of people agree with you. Less than 1 in 10, Louise.
Oh, no.
But the PhD students, they're always the smartest in the room. Always. Declan, what do you think? Does prostate cancer spread to axillary nodes?
Well, I voted with Louise on that one, I must say. And one of the things that I think PSMA PET-CT has taught us is the quite extraordinary distribution of prostate cancer in the body, even in patients you think have localized disease or loco-regional. And we usually think that the lymph nodes are in certain templates, but guess what? They're not. They're in the mesorectum, they're in the presacral region. So I think PET-CT has shown us the extraordinary ability that prostate cancer has to metastasize to odd places. And because the specificity is so high, when these things light up like that, not like a celiac ganglion, this is, in a guy with metastatic cancer, I'm usually very, very convinced. We published a big systematic review like this about this in European Urology, and that was one of our big findings, is the specificity is very high. When they light up like that, you got to presume it's prostate cancer in that type of location in a guy with metastatic disease.
Michael, was that 7% from the panellists voting for that number 3?
Oh no, that's the audience.
That's
And
the
all
audience.
I was told there are 300 people online virtually, in addition to what we see in the audience. So we've got a lot of people voting. So that's statistically significant. The p-value for that was 0.01, I'm told. But of course, this lymph node, this is the follow-up PET. You can see that it progressed and it's had an SUV of max of 54 a few weeks later. So these were clearly malignant. And do you want to talk us through this paper, Zeting? There's a study on COVID for everything.
Everything. You name the tracer, and it's got a COVID slant to it, because that's how you get published these days. Internal medicine, anything with COVID will get published. So this paper quite nicely showed, and that was in PSMA 1007 that you all heard about before, and saw that there was actually quite a bit of I can't see that. It was metastasis, I think. In that far right graph. Yes.
Yeah, that's right. So on the y-axis is the SUV max, so it's a lot higher, whereas the other three boxes are for the nodal react. Anyway, essentially there was a group of patients with COVID vaccine. Some of them had none, so you had controls. And there was a slighter increase in those who had a vaccine, but only around 2 to 3 SUV max. So it can be mildly increased, but nothing in the order of 17. Once you get above 4 or 5 SUV max, it's already getting a lot more suspicious than that low-grade uptake.
And I think once you get an SUV max, there's no rule, but it increases with higher intensity. Once you've got an SUV max over 10, it's extremely likely to be prostate cancer and nothing else. In that 2 to 3 range, that's when you need to think, could it be reactive?
That's right. And we might move on to the next case, because I think that's where the SUVs get a little bit more interesting.
Case 4, a 67-year-old who presented with slowly rising PSA up to 5, and previously Gleason score 3 + 3 = 6, so a grade group 1 cancer, has been on active surveillance, had low-dose brachytherapy in 2008 and was referred for slowly rising PSA. Is this an appropriate indication for PSMA PET, Shankar?
So, I think this is not the kind of patient you would normally be looking at for PSMA PET. In general, we'd be using conventional imaging, but in this modern era, when you have a patient who's been previously treated and having a rising PSA, I think it's very reasonable to be using this tracer.
James, do you want to show us the images?
Yes, with pleasure. So you can see the PSMA PET here, essentially very high, moderate to high uptake, so 13 within the prostate. So you can see the seeds are there, the brachyseeds, and there is in-bed recurrence. And interestingly, there's no evidence of any nodal metastases. You do go down into the inferior pubic ramus to the left. There is a mild uptake, so SUV max 4.5 approximately. There isn't anything visible on the CT, though it is perhaps slightly more sclerotic, but quite subtle. So that's the only finding. It's mild degree, so that's it. No metastases elsewhere.
Yes, I guess we could debate whether this is a metastasis or not. If we follow the rule from the previous slide, it's low grade. Maybe it's benign, but it's got an SUV of 4.5. It's getting up there. Declan, what do you think?
And that we do review these cases in MDT all the time, Michael, don't we? And 2 comments. The first is that we'll usually give a patient like this the benefit of the doubt, because the likelihood of metastatic disease is extremely low based on his clinical background. And we would definitely, if he was someone suitable for curative intent salvage treatment, we would offer him a biopsy of the prostate. But I think the bone thing we would give him the benefit of doubt on. But the second comment that just struck me watching these beautiful images that James is presenting is, again, it's an important reason why we need to look at these images together, and using this type of software, MIM, which you all use, which we don't normally get access to. When we log into the hospital system, we see the more straightforward PACS system, and in most of our private providers, it's a very good PACS system, good for MR, but you don't get this degree of separation and being able to separate out the contrast sequences, which is fantastic for looking at the ureters, etc. So it just strikes me that that's certainly worth talking about, is the way you folks can show us these images using very advanced software is incredibly valuable for how we make these calls. Because if this was just described as metastatic thing and there was a screen grab, you might just treat it as such. But when you review them in an MDT with expert teams, we would give that patient the benefit of the doubt, I think.
James, do you just want to wind this up and down just so we can see we can wind these
Yeah,
pets up and
that's
now
the
it
screen
definitely
grab,
looks
that's
like a
what you'd see.
metastasis,
Yeah,
right?
that's
Or
amazing.
we can wind it down and it looks faint and not like a metastasis.
I don't know, there's not just one. I
Oh
can
my
see
God,
hundreds of them.
the whole body's...
And Michael, that we still do see a lot of that, and the whole bowel is glowing green on the fused images, over windowed and so on. But I think because there's now a lot of experience of PSMA PET CT in Australia, as people have gained experience, we see less of that. But I think for the US in particular, where there's going to be a lot of early experience of PSMA PET CT rolling out, I think this is a really big pitfall people need to be very careful about. The Wild West of PSMA PET imaging, when if you don't have as Tom said earlier, appropriate acquisitions, appropriate protocols for reporting, then there will be, some misleading guidance, I think, misleading interpretation.
So it's important to know the distribution of prostate cancer metastases, and if it's in a spot that's very likely to be prostate cancer, then you need to sort of wind up your suspicion and lower the intensity of uptake. So what about this location, Declan? Do you think this is a typical location for a metastasis?
Yeah, for sure it is. However, I suppose if we think of the initial disease, it's actually a type of cancer we wouldn't even treat nowadays, a low-grade cancer. And I didn't see his PSA, but it's like 2 or 3 or something, slowly rising. He's got a focal hotspot there. Could that have transformed into a high-grade cancer that could metastasize? Yes, that's why we would biopsy the primary. And if it turned out to be, a 4+5 grade group 5 cancer, it probably would be a different way we might interpret this. But generally speaking, we'd be inclined to give someone the benefit of the doubt, I think, if all he had was a little bit of recurrent grade group 2 cancer.
Might go back to the slides. Are we going to do an audience poll?
I think George has a question. Yeah.
Mm.
Often that is a guide. If there's poor coverage in that area, it's very likely a local recurrence. And I think that's what Declan is thinking.
Yeah.
This guy, and surely Chandler is too, who might benefit from retarded, say, the
Reirradiation.
So George is just making the point to look at the CT and where are those seeds? Is there a bit of a gap there? I think we do see a local recurrence on the PET. Maybe the metastasis is more likely in that setting. Most people think this is definitely a bone metastasis, which actually we agree with, and that's because it's a common site. Prostate cancer likes spreading to bones in the pelvis, and we've done some research on this. Might let James talk about that.
Yeah. Can we flip?
Go back to the slides,
Yeah, just go back
please.
to the slides for George. There's the...
Sorry, to MIM.
Oh, yeah, to MEM. So yeah, we do see there were...
Hang on a second.
Yep.
Thanks.
Yeah, because the left half of that gland at the apex looks very poorly.
So you'd almost describe it as local persistence of a cancer from 10 years ago. It was a low-grade cancer that's now probably a higher-grade cancer rather than a local recurrence per se. And the rest of the cancer, the rest of the prostate's well treated.
Could you rebiopsy it to confirm high grade?
Definitely. Because the specificity is very high, as you think, but we've definitely seen 1 or 2 that we've biopsied these and it's not. And it's such a big deal because salvage treatment, even focal reirradiation, can be morbid, but certainly prostatectomy or cryotherapy, whatever, can be very morbid. So I think you need to know for sure. Yeah.
Great.
Micah, back to the
Thanks.
slides.
Slides,
Yeah.
please.
Yeah, so there had been the first in human nanocolloid injections done at Peter Mac, so for sentinel node imaging for patients with prostate cancer. So there were injections directly into the prostate, and quite an interesting series of patients where you do see many typical sites where you do expect to have some drainage, but also many atypical ones. In the image here, you can see some up in the thoracic duct. There were some up in the supraclavicular nodes in the Virchow nose, as well as one patient who had direct drainage into the left inferior iliac. So just good reference.
So I think what we saw in this study was some drainage via venous plexuses in the pelvis from the prostate into that exact location in the inferior pubic ramus, and we see that as a site of metastasis quite frequently, and it's not hematogynous. It's a loco-regional pattern, even though it's in bone.
Great. We'll go on to our next case now, which is a 63-year-old with a recent diagnosis of prostate cancer, PSA of 24. Biopsy showed Gleason 4+3 = 7, grade group 3 disease, and he was referred for consideration of local definitive treatment and had a PSMA PET scan done. Next slide. Yep, so James.
Yeah, so this one, I just have the screen cap. So you do see PSMA PET to the left, and there's a very highly avid prostate cancer that you can see with a little asterisk, SCP max around 40. And then you do have widespread small volume bone metastases, so well over 20. There was little to no change on the CT for the vast majority. And interestingly, there had been CT done as well, so we did have the conventional imaging. This was a case of pro-PSMA, and you had very low volume disease, so only 3 sites with mild uptake on the bone scan. So it just brings into context that concept of low versus high volume that Wolfgang actually discussed.
It's a quite amazing difference between the PSMA PET and the bone scan.
Yep. Yeah, so questions for the panel. So are bone scans still necessary, or should we just do away with them?
I think in this case the bone scan was extremely useful. I have no doubt that it's a real finding on the PSMA PET scan because clinically this is a high-risk prostate cancer based on the PSA criteria of 26. But the fact that on low-volume disease on the bone scan, that's what drives us on the clinical practice, because the randomised trials that we have available are based on conventional imaging. So, for example, this kind of patient still would benefit from local therapy, and it might be that this patient, there's a STAMPEDE trial, and of this, one of these arms of the STAMPEDE trial was cohort H, which had a benefit for using radiation treatment in the localised prostate cancer. So this is the group that had basically standard of care systemic therapy versus systemic therapy and radiation in low volume metastatic disease. And there was a very large benefit from the use of radiation to the primary, a relative risk reduction of 32% at 3 years, so quite significant for men. And so this patient should have radiotherapy, even though from your own logical sense you might think they have widespread disseminated disease and just have systemic therapy alone.
Can I be the devil's advocate and say, that study didn't incorporate PSMA PET. This is not the same beast as the patient in the STAMPEDE trial with low volume disease. The data Tom Hope showed us earlier was over 40 mils, was probably, maybe you can convert between the two. This is one where the bone scan just got it really wrong. This patient's going to do badly even with radiotherapy to the prostate. But we need to redo STAMPEDE. What do you think, Declan?
I disagree with you. Because, well, look, 2 points. One is that this patient was in a trial, so ended up with both types of imaging, and so we could compare the primary endpoint. But remember, the trial which you led was designed to substitute it out. So actually nowadays, that patient wouldn't get a bone scan in Australia. He would have had a PSMA PET CT, would have showed widespread metastases. And the concern that the global prostate cancer community has with that shift in management, a shift in diagnostic pathway, is that we will treat that patient as a high volume patient and he will not receive radiotherapy to the prostate as Shankar recommended. And that, there is evidence of an OS for very well tolerated radiation to the prostate in that patient. So the question for us when he comes in with that scan is, well, would this be low volume by STAMPEDE criteria? So we're always trying to, do we need to do a bone scan or can we just subtract it out? And in the MDT we'll often just, not particularly that case, but in other cases we'll say, look, we should treat this as a low volume and give him the radiation to the primary because of the OS, the tolerability, etc. So I think it is still important that whether you do the scan or not, the bone scan, that you understand there's some very good data that guides decision making based on conventional imaging.
Great. But Michael raised a good question just now, should we be doing PSMA PET for all these patients now, as we do mainly here in Australia? So if you only had the PSMA PET without the conventional imaging, how does that change your management? Both of you and also Louise, would you?
I think from a systemic therapy perspective, the volume of disease nowadays doesn't make too much of a difference in terms of the options available and how you decide which agent you would prescribe. It's more from a trial point of view, as Shankar mentioned, working at Peter Mac, which is a very academic centre with lots of trials. Patients are still eligible based on having measurable disease based on RECIST on the CT or measurable bone lesions on the bone scan. So even with that PET finding, if the patient was suitable for a trial, that would always be the preference, and in that case I would still do conventional imaging.
Would you send them for lutetium PSMA treatment?
Oh, it depends, I guess, what their prior treatment is. Are they hormone sensitive? So
that might be a question for tomorrow.
Yep, not yet.
That's all right. Just throwing it out there. Okay, all right. We might move on to the next
Next
slides.
case. At some point, we're changing the panel, aren't we?
Yeah,
Yeah.
I think this is about midway mark. So we'd like to thank our current panel, especially Shankar and Declan, and we'll switch over to the next lot of radiation oncologists and surgeons. We invite Louise to stay on because unfortunately Shanine is not well and is unable to be here this morning. So thanks for staying on, Louise, and taking up some of Shanine's time. No worries. Come on up.
So we're going to welcome back Dr. Renu Epen, urologist, who is also doing a PhD in PSMA theranostics. Not joking. We have a urologist, nuclear medicine, and medical oncologist, all doing PhDs in PSMA.
Now, Genevieve, you know that's
Genevieve-
your cue next to do
Yes.
a PhD now, right?
Genevieve is a radiation oncologist
That's right.
from France who's been with us for quite some time now,
Yeah.
almost a year.
Almost a year, and
Had to endure a few lockdowns, brought her kids out here, and then we went into lockdown, and she was thinking, why did I
Should have
come
done
to
your
Melbourne?
PhD then. You would have finished by now.
And is heading back to France in
yeah.
a few weeks' time.
3
So
weeks.
Oh,
Before you
Welcome to
rope
the
her into a
panel.
PhD.
I'll enjoy my.
Yeah. So to round off an amazing year, we brought her to a French-themed hotel.
Is it as good?
Yeah.
Les canapés sont bons.
Case number 6. This is a 64-year-old man who's had a radical prostatectomy in 2012. A Gleason score of 9, grade group 5. Now, for those who aren't familiar with what grade group means, you need to go off and do some reading after this because the nomenclature's moved from Gleason score across to this ISIP International Grade Group Scoring System, so you'll quite frequently see that on your referrals, and you really need to know what that means because it helps you adjust your sensitivity. Is this a low-risk prostate cancer or a high-risk prostate cancer? So pro-PSMA included grade group 3, 4, 5. So 3 is sort of your intermediate high risk, and 4 and 5 is high risk. This patient had undetectable PSA for 3 years. So the surgeons were seeing the patient every 6 months saying, it's great news, we've cured you. But then the PSA was starting to rise, 3.5, with a doubling time of 2 months, meaning the PSA is doubling every 2 months, and that's quite a rapid doubling time. For those who aren't familiar with PSA doubling times, we kind of divide that into less than 10 months, which is rapid, or greater than 10 months, which is slow. So 2 months suggests this is definitely disease and that it's probably fairly aggressive disease. Now, I guess the PSMA PET's requested to localise where this recurrence is, which is an entirely appropriate indication, and James will show us the scan results.
Right, so you can see here the PSMA PET, the pelvis right here, there are multiple clips. So this patient, just to remind, did have radical prostatectomy in the past. And you do see moderately avid nodes, moderately to highly avid nodes in the left-sided pelvic chains. So you do see some internal iliac, external going up into the common iliac over here. And they do extend all the way up into the retroperitoneum. So you have some aortic, para-aortic, as well. So it is a disease there is N1 disease, but also M1A. So there are metastases. However, there are no metastases past that point, so approximately the height of L3, no bone visceral metastases.
So how big is the largest node?
The largest one, they're all I think they're all sub-centimeter. So if you just take this one, it's around 8 millimeters.
So they look,
So
they kind of look bigger than that on the MIP images. They look really chunky.
Yeah, this one
What
would
about
probably
that
be the largest. Yeah, yeah. So
But
you
they
do
are
have-
pretty small. So we get a light bulb effect with
one-
PET scanning. If the tumours are very PSMA avid, they'll take up a lot of tracer and they look really big, a bit like looking into a old-fashioned light globe, 1 millimetre filament, but you look straight at the globe and it looks big. So it allows us to really identify very small volume disease. Now, the really observant people in the audience have noted the date on that scan. It was March 2015, so 7 years ago. So this was a very early use of PSMA PET, and when we saw these in our MDT 7-8 years ago, it created a lot of confusion because what do you do with this patient? Is it even real? Do I want to maybe confirm? These are tiny nodes, they're 3 millimetres, is it really disease? So the question 7 years ago would have been, should we histopathologically confirm this? And if I was a surgeon at the MDT, I'd be saying, Renu, I think we should do a pelvic node dissection for two purposes. One, to confirm these PSMA PET findings, because I don't really believe it. And two, maybe we can improve the outcome by cutting out all the tumour that's now left behind.
Yeah, this is this is the classic Pokemon phenomenon that you're kind of alluding to here. And Declan wrote the paper on this in, was it 2017, Declan, in European Urology, and this concept of cutting out METs as they come up. And I guess the question is, are we really making a difference in terms of their disease recurrence and recurrence-free survival? And I don't think we have enough evidence to really suggest that helps. Although this is kind of high volume nodal disease, the kind of PokeMet phenomenon is sort of when you have low volume or oligometastatic disease and you sort of hit them over the head and wait for the next one to pop up and hit that one. But this, this is a man with a short PSA doubling time. There's nodes that are up high, so this is indicative of a systemic relapse.
So you wouldn't be recommending a retroperitoneal nodal dissection?
I would not be recommending a
Genevieve,
retroperitoneal
would
nodal
you
dissection.
irradiate all this tumour? We can just do a little extended field of radiation, get rid of all the disease, try and cure the patient.
We've made a lot of progress for irradiation. I wouldn't go for that because it's going far too much higher in the fields.
So one of the themes at our MDTs, 5 or 6, 7 years ago was just because you can see it on a PSMA PET doesn't mean you need to treat it. You don't need to cut it out or sabre it. This patient may need systemic therapy, but a sort of local regional approach is probably not worth it. So we said, just because you can see it, you don't need to treat it. And then in 2016, we hosted the Theranostics World Congress in Melbourne. It was at Peter Mac, and the theme of the Congress was, can you remember what it was, Declan? It was,
If you see it, you can treat it.
if you see it, you can treat it. And Declan was like, at the MDT, you're telling me just because you can see it doesn't mean you have to treat it. And then you're running a conference and the theme is, see it, treat it. Confusing me.
You can treat it, you just shouldn't.
And look where we've come 7 years on.
Maybe we can go back to the
Slides, please.
I think we do have follow-up on this patient. I can tell you for whatever reason, this patient was subjected to an extended retroperitoneal nodal dissection. That was deemed the appropriate treatment at the time. And 4 months later, you can see the result of that. Do you want to take us through the results, James?
Yes, you can see, we can flip back if you want back to the MIM screen actually, but you do see there was an extensive retroperitoneal and pelvic nodal dissection. And unfortunately, you do see it was quite rapidly progressive disease. So you do see nodes. There was one node that was still in the pelvis, but you also see some coming up in the retrocrural. Sorry, I'm just back this up. So there is one also retrocrural. It did creep all the way up into the mediastinum. There are 2 bone metastases as well. So it did spread quite quickly, and it went all the way up into the left cervical chains. So just a few months later, it did spread quite quickly.
Back to the slides.
Back to the slides. Yeah, so Declan, as you alluded to, wrote a editorial in European Urology titled "PokeMets Got to Catch 'Em All," and it was the message here was that salvage lymph node dissection or stereotactic radiotherapy, you may be feasible for that, but is it worthwhile? And you do need to select patients carefully. Do we really need to ablate all these lesions? And the long-term outcomes may not be any different. And in that short time frame, systemic therapies has evolved. Louise Kostos, what would be the appropriate, medical oncology treatment in a patient like this with a PSA doubling time of 2 months?
Yeah, I think in a patient with a short doubling time and relatively high volume nodal disease, systemic therapy is definitely warranted, and we can no longer say androgen deprivation therapy is enough. We do have to have a discussion about chemotherapy with docetaxel or one of the novel anti-androgens. There's now even an argument for triplet therapy in some patients. We are limited in Australia, though, as the anti-androgens, so enzalutamide and abiraterone, are not subsidised on the PBS yet. So It is a bit of a nuanced discussion with the patient, but it would definitely be ADT plus one of those agents. Yeah. And I think I agree with Renu and Genevieve in that with the doubling time that quickly, loco-regional treatment I think would be inappropriate because the concern is micrometastatic disease that's being missed on the PET scan, which is clearly what happened and recurred.
Great. Thanks for that, Louise. And so we might move on to the next case now, which is that of an 81-year-old gentleman who presented with de novo metastatic prostate cancer, had grade group 3 disease. He was on a trial and he had a PSMA PET done pre and post enzalutamide, and the PSA did decline quite a little bit from 390 to 210, but the SUV max was rising. And we might go on to the next slide, please. Yep. And so the MDT discussion was whether this was actually progression on PSMA PET.
Yeah, we could show the images.
We might have to get Louise back up to the panel to mic
Yeah.
up. Where
I think the audience is already an expert now in this domain, right?
Exactly, I think so too.
So this was a patient with who was treated with Enza. You see to the left it was pre, and then post to the right, with the fused images in the middle. And overall, there was an upregulation. You see an increase in SUV max in most of the lesions, around at least 50%. You have this one, for example, in the proximal right femur. It went from 30 all the way up to 45. Lower dorsal spine as well, from 40 to 60. And even the number of lesions does seem to have increased. A lot of them just are a lot brighter, probably some that just were below resolution as well previously.
Mm. So Louise, sorry about that. So Louise, so knowing that, actually we've got two Louises in this expert panel. So knowing that ENZA does upregulate, like what we've heard before in the previous session, and now seeing the proof for yourself, how would you actually go about treating this patient? Would you actually, what would you actually do?
I think that's a really good question, and I don't think we have the evidence just yet to say that we can, give enzalutamide prior to each dose of lutetium PSMA or continue it concurrently. But I think potentially that will be standard of care in the future. As Louise mentioned, we do await the final results of the ENZA-P study. But in the VISION trial, which we'll hear about later today, in the arm of patients who received lutetium PSMA, I think about half of those patients, about 52%, were receiving concurrent anti-androgen therapy as well, and they actually did better compared to the group that weren't receiving the anti-androgen therapy. So it does seem to be synergistic, and I think potentially in the future, but not just yet.
As you mentioned, it's not funded, so that always plays into, it comes into the picture as well. So we might go on to the next. Back to the slides, please. So actually, we might look at some of these response criteria that Tom talked about earlier, and particularly this proposal for the therapy response assessment criteria, the PSMA PET progression criteria. Michael, would you like to comment on this that was released?
Yeah, the PPP criteria. So this essentially defines sort of 1 or 2 new lesions. So you're not, a change of intensity of uptake alone does not define progression. Even if your SUV's gone from 30 to 60, that's not progression. You've got to have new sites of disease. That's the key here. And I think that is an important differentiator. If you do the same PET scan on a patient every day for 7 days, the SUV does have some natural variability, and that has been looked at. Here's a study of gallium PSMA 11 where they took the same patients, intra-patient variability, 14 days apart, repeated the PET, and there was a variability in SUV, which was quite consistent with FDG. And there's also a study of DCF-PYL showing exactly the same. So these are, the SUVs are quite reproducible, but you will have a variation as much as kind of plus or minus, maybe even up to 30% at the extremes. Just routinely. The same with FDG. So you do need to have a big difference for it to be significant. Throw in a drug like enzalutamide that's not actually causing progression, but just upregulation of a receptor expression, then you may get a doubling of SUV and it's not progression at all. It could be response. So we really do need to be seeing new sites of disease. I think throwing in CT is very useful. If it's a lymph node, is it getting bigger? If it's not getting bigger, it's not progression.
Correct.
Bone's more difficult because you can't really measure it. Whole body MR, which is not really done in Australia, is useful for measuring these bone lesions. May be useful.
Thank you. Good. We'll move on to the next one.
Case number 8.
Yep.
PSA of 30. MRI shows a PIRADS 5 lesion. Now, PSMA PET shows localised disease only, node negative. And the patient had a robot prostatectomy, which showed Gleason grade group 9 disease, which is grade group 5. That's the highest group of risk, and now is re-referred with slowly rising PSA. Only 0.7, so quite low, below 1, doubling time of 12 months. That's a little bit unusual, but that's this patient, so they've got kind of a lower kinetic recurrence, even though they did have aggressive disease initially, and we're now 1.5 years after the prostatectomy, and we're going to look at the PSMA PET to try to localise the disease, and James will show us the images. James, is this a gallium, PSMA 11, or a DCF-PYL, and does it matter?
No,
We've heard that it doesn't matter.
That's a trick question, yeah.
Next question.
All right, next case, yeah.
Tom saying.
Just out of interest, yes. What tracer was this?
So this was, it's written dopamine, so I just have to... Oh, no, it's gallium. There you go.
Gallium, all right.
It was
I
gallium.
think there are a few little subtleties there, more for not relevant for the referrers, but relevant for us nuclear medicine reporters. We do see sort of slightly higher incidence of ganglion, maybe benign reactive nodal uptake between these tracers. So when we look at them, we do want to know what tracer it is, and it makes some very minor nuance difference, but we agree that they are both equivalent. And in fact, that rumour I shared recently about funding, that in Australia the funding will be tracer agnostic, so it will apply for gallium PSMA 11 or the fluorinated DCF-PYLs or even 1007.
So I think from our perspective as nuclear medicine physicians is to make sure that we know of these pitfalls and actually apply that in our clinical practice when we're actually reporting it, to make sure that we're not overcalling things, because that obviously does make a difference to our referring team. So yes, we might actually get James to go through the scan quickly.
Yeah, thank you. So you can see this patient had the radical prostatectomy, a little bit of a more elongated bladder there. There's nothing in the prostate bed. We do go through those pelvic nodes, nodal regions, and there's nothing. Can increase the intensity just to make sure we aren't missing anything significant where we could expect some disease. So there's nothing there. And if we go back to that 15 window, look at the MIP. There is one site with mild focal uptake in the vertebral body of T2 right here. So we'll just change windows, but it is left-sided, mild, 3 SUV max. If we do have a closer look, there isn't anything on the CT, and in other planes, we do see that it really is, it's not between two vertebrae, it isn't degenerative change. You don't see any herniation, so it is really spot in the middle there.
Can you dial it up for us just to...
Yes.
Convince us it's met?
That's a great situation where you want to dial up the disease a bit and just increase your sensitivity.
Are we taking a vote on this one, James, or not?
We are. There's an audience poll. And
There is?
Oh, yeah, fire up that app. We want to know, do you think this is a metastasis?
Back to
nothing
the
on
slides,
CT,
please.
T2, SUV max of 3.
Audience poll?
Audience poll. I'm not sure what the options are, but you can say it's definitely a metastasis, it's equivocal, or it's definitely benign. We'll give everyone a second to vote. Now, I'm told that for the people online, much like live TV, sports, it's not exactly live. There's about a 20 to 30 second lag.
Oh dear.
That's so that if I was to slap you, they would...
They can edit that
they
part
would
out.
edit that. They would cut the audio out. They need to be ready for that, which means we need to go slow because they're not seeing the questions online for about 20, 30 seconds.
Okay, so we need to give them a bit more time.
But it means if we do start hitting each other or swearing, they will pause that and cut that out.
Excellent.
So more and more people are thinking this is an equivocal finding. So if we use the ePSMA guidelines, James, what would ePSMA say? How to interpret this?
Yeah, so this would be a 3. So essentially, there is some mild uptake. There is some uptake, however, it is in a place where we do expect to see some metastases. It isn't just a so it would be equivocal, but in a place where we would expect it.
Yeah, and Declan, what's the best test to diagnose this?
Declan or Renew?
Renew. Sorry.
Well, it is equivocal, but like James said, it's sort of in a place where you would expect a MET to be. But sometimes the best test is just waiting and seeing.
Best test is waiting and seeing. That was the answer I was looking for.
Oh, really?
Yeah, but I didn't think you were going to come up with it. We tell our trainees the best test. It's not PET.
Time.
It's not MRI. It's not biopsy. It's time. And here we have the luxury of time because this patient had a staging PSMA PET 18 months ago. So maybe if we compare the two, that'll be informative.
Back to
James, do you want to maybe compare? So it's important to get the prior imaging back. Because if this was there 18 months ago and it was faint and it hasn't changed, it's benign. I go from equivocal to benign. It hasn't changed
Back to Mim, please.
in 2 years. But if it's the same tracer, this is not... If this was PSMA 1007, which we know has a higher rate of benign bone uptake, then we might think it was benign as well, because we know that that tracer has some much higher incidence. But these are both gallium-68 PSMA PET. They're both scanned on the same camera. The imaging technology hasn't changed. The uptake time is 60 minutes. It's the same. So there's been no change in imaging technology. But tell us what it shows, James.
Yeah, so if we really wind it up just to see was there something there before, you really do not see anything. So it is a new finding that appeared in the interval, less than a year, about so in about 9 months, and there was absolutely nothing there on CT nor on the PET.
So what would you conclude from that?
So I'd conclude that it is there is a high probability that it is single-sided metastases. So we would upgrade it from being equivocal to
Solitary metastasis.
probably a metastases.
Yeah, so let's say it was even more intense so that we were very sure this was a metastasis. I think we'd be referring the patient to you, Genevieve, to say, will you eradicate this for us?
Whatever I choose, I would, before doing SBRT, I would ask for an MRI. So that probably pushes me for taking my decision. And because I'm really confident in what James is telling me, I would say I'm in the configuration of an oligometastasis disease in the bone. And we've got, I think, few phase 2 paper that would push for that treatment. And yeah, I'll discuss that in MDNT and choose for SBRT, I think.
Louise, what do you have to add from a medical oncology perspective? Does this patient need systemic therapy, ADT, or even ABI enzalutamide, or is SABR appropriate?
I think with a solitary metachronous metastasis with a very slow doubling time of, I think it was 12 months or even slower, the patient could just undergo SABR and then be observed. I don't think there's a strong indication for systemic therapy at this stage. That would change, though, if the doubling time was much faster, say, for example, less than 3 months. In that situation, I would consider starting systemic therapy or at least very close monitoring of the PSA following the SABR.
I mean, this is a very different situation to the case that we presented before with the, fast doubling time, lots of nodal disease.
Yep.
I think Shankar wrote a reply to Declan's PokeMet paper, and there are some very desirable PokeMets, right? What Snorlax? This could be Snorlax. that may do well with treatment.
Might go back to the slide. So this is an area of international debate, whether SABR is appropriate in this patient. There is a new lesion. It's highly likely to be a metastasis. And probably in our institution now and around Australia, these, many patients are being referred to radiation oncologists, and SABR is being used. Maybe do you want to tell us a little bit about some of we only have phase 2 data, but there is this Oriole paper
Yeah.
Genevieve, maybe you can take us through it.
Yeah, that's one of the few papers that show phase 2, and that was observance versus treating with ACBR in that situation. And obviously, people who received ACBR had only 19 progression, and it was very much higher in the observation arm. So, but what I do, I'd say in the end, with only phase 2, I can't firmly say what's the best for the patient. So what I will have the best to do for that patient is to enroll them in a phase 3 study. And we've got that already in France. It's a JETUC-promoted study that is done by Pierre Blanchard. And that is typically, in that situation, will offer the standard of care treatment, which probably would be ADT plus a second generation hormone and adding SBRT on the lesion.
Thanks. And just to come back and do the thought experiment, if this was PSMA 1007, this is being used in some places in Australia. I think like Brisbane, Adelaide and Perth are using quite a lot of PSMA 1007, whereas the rest of Australia is using more DCF-PYL or gallium PSMA 11. James, do you want to just tell us about this interesting paper on comparing gallium to PSMA 1007?
Yeah, actually, Tom did refer to it as well, but as he put, you can see the graph to the bottom right. Essentially, 1007 does have approximately 5 times more benign findings that are PSMA avid. So you can see in blue at the bottom, those are the findings that were prostate cancer, the metastases, compared to in orange, a much higher amount of benign findings with PSMA uptake to the right, which is 1007, and to the left is the gallium PSMA 11.
And why is that?
Why is that?
You put your own student on the spot.
Why? It's a reflection of my bad training. I know the answer.
I'm sure you.
Is this where we cut the webinar?
That's the 20-second lag.
We'll discuss this tomorrow. No one really knows, actually.
Okay, good.
So there's no answer. It's all right.
Ziting, do you know the answer?
Nope. There's no answer to that.
I think the answer is, I think we think it dissociates. You get a bit of free fluorine.
Oh, right.
But if you do high quality control on the tracer before you inject it, it's very robust. There is no dissociation of the fluorine from the fluorine PSMA 1007 conjugate. So it's inconsistent.
Yeah.
But what we believe happens is once it's injected, maybe it undergoes a bit of lysis in intravenous circulation, and then you have a bit of free fluorine, and you can do a bone scan with fluorine. So if you've got just a tiny bit of fluorine around unbound, it'll get taken up into degenerative change, fractures, benign bone lesions.
And in those circumstances, I guess you might see more bony uptake as well.
Yeah.
There really is a lot.
But
of
importantly, this does
dissociation.
not seem to happen with DCF-PYL.
Yeah.
It does not seem to dissociate.
Is Tom here? Does he have any thoughts on what the cause might be?
I think it's the lipophilicity of it, gives it a non-specific binding. Like what makes it have more hepatobiliary clearance is that it's lipophilic, and I think that binds more in those, but that's totally unsubstantiated hypothesis.
As well. There you go. Many thoughts. All right. On to the next case now. A 66-year-old man, post-radical prostatectomy, Gleason score of 9, grade group 5, with positive margins, PSA of 22. Conventional imaging did not show any metastases, but his PSA remained at 2.5 post-operatively. So the question for the MDT is, would you proceed with salvage radiation without having a PSMA PET? I guess we might not be here if you had another thought, but anyone want to go ahead without a PSMA PET?
No, I wouldn't. No.
Okay. Well, we might have James show the images.
Next question.
Should we ask the audience? Yeah, no, so we did take a nice case. We can change to the immense screen, please. So this is a good point.
Second.
Yeah.
I think be a brave person to actually go ahead and treat them without a PSMA PET in this day and age, isn't it? So
Yeah, and I think this patient probably should have had a PSMA PET prior to the prostatectomy because they did have very high risk disease. So as per the PRO-PSMA trial, they probably would have benefited from a PSMA PET prior to making the decision to proceed to surgery.
great. We'll look at the images now. Thank you.
All right, so good call, Geneviève. There is widespread nodal metastases, so throughout the, just have open here, but you can see some throughout the pelvic chains, going up into the retrocrural, some in the posterior mediastinum, I think there were, and up even supraclavicular on the left side. So quite extensive nodal metastases.
Excellent. So, are you showing yours?
No,
Okay.
I'm good.
Can we
can
go back to the slides, please? So I guess this is where the really, as mentioned many times before, today one of the seminal papers obviously is the PRO-PSMA PET, which is superior to conventional imaging for staging of prostate cancer with high-risk features. So, and as Louise mentioned before, and I think it's probably accepted now, not just in Australia, but pretty much around the world, that PSMA PET would have been warranted in this patient. Any other comments from our panel? No? All right, well, we will move on to the next case, which is Michael.
Case number 10. Is this the last case?
Oh, we've got one more after this, a
more.
special one.
Bonus case.
Yes.
Fantastic. And then lunch.
Yep.
Case number 10. 68-year-old grade group 4 prostate cancer. PSA is 23. Referred for curative intent treatment. Conventional imaging staging was normal. And James is going to show us his PSMA PET.
All right, so you can see the prostate cancer, the peripheral zone left posterior mid-prostate. Mildly avid, so mild to moderate S7 SUV max. It isn't quite striking. We don't see any nodal metastases, so we go through quite the higher intensity in those pelvic chains just to increase our sensitivity. There's nothing suspicious that stands out. Have another look in that SUV 15 window, and looking at the MIP, so the only thing that does stand out, just increase the intensity a bit, but you do see one focus of mild uptake in a rib right here. So again, it's something that depends how you window. If you bring it up a lot, it does stand out quite a bit. Could be alarming if this is like the fused image in the PACS, for example. When you window it a little more appropriately, it's quite mild. And then on CT, there are some mild sclerotic changes. Very subtle, though. Looks well circumscribed, though.
And what's going on in the trachea? I kind of see the tracheal outline on this scan.
Yeah, we do see trachea and also a lot of, you see those ganglia that stand out, sorry. So these are two common normal findings that we see quite frequently. And you see the ganglia right here as well. And then bronchociliary activity.
Yeah, so a little bit like the salivary glands, the submucosa that tracks along the trachea that kind of makes your mucus has some PSMA expression. So you see that, particularly a little bit more with DCF-PYL than the gallium, that tracheal pattern of uptake. So who thinks this is a rib metastasis? I don't know that we have an audience vote on this, do we, or
Do we
not?
have a poll?
I believe so.
Can
We
go
have a
back?
poll. We want to know, is this a rib metastasis? It could be a benign finding. It could
Should
be
we
an equivocal.
tell what tracer
Could
we're
be
using?
intense. It is
Have you
DCF-PYL.
said the SUV max of that?
Was
Or is it
3,
PSMA
I believe.
1007? So you can see a little bit of a theme of this
2.2.
MDT has been these
Very
tricky
mild.
cases. If it's really intense, it's easy. If it's got an SUV of 20, it's prostate cancer. It doesn't matter what tracer you're using. It's really easy. These are the ones that you need to get a better feel for. Low intensity uptake, low SUV. Then you need to know where is it,
What was the SUV?
which tracer is it,
2.2.
what's the grade group, what's the likelihood of metastases, and you need to put all those things together to try to guide you. Is it malignant, equivocal, or benign?
So this apparently was a SUV of 2.2.
SUV of 2.2.
Okay, can we have a look at the audience poll, please?
There is no audience poll.
Oh, there's
there
no
was
audience
none.
poll.
That's
That's fine,
okay.
okay.
All
We'll
right.
have a panel poll instead. Renew.
Met, no met.
Three choices.
You can tell time is.
If you don't know, just pick C.
I think it could be a Met.
Could be a Met. Louise.
I think because of the location and the low SUV, I'm going to say Equivocal.
Equivocal.
Sit on the fence.
Genevieve.
I would say quite the same and give the benefit to say it's not met and treating him as it.
Zeting.
I'd say it's equivocal as well.
Oh.
Probably not a met.
Okay, I changed mine to
but-
Equivocal too.
But I'd say probably not, and then we just
Probably not, yeah.
repeat the scan.
I probably thought this is
Not.
probably benign.
Yes.
James, what did you report it as?
Yeah, probably benign also. Quite
Yep.
frequent.
Yep.
But were you right?
Finding these.
Do we
I
have
don't know.
a
Do we have
follow-up?
time?
Do we
Do we have the best
follow-up?
test?
We don't have the best test. We
No,
only have our-
We do
sorry.
have time. We've got
No,
5 minutes
no,
left.
as in time on this patient.
We just have to
Did we-
change.
Okay.
Oh no, we don't have.
We
any
don't have a
follow-up
follow-up
for this one,
yet.
no.
Okay.
So this was reported as probably benign.
Yes.
Quite frequently see these very mild uptake, very well-defined slight sclerosis, but nothing concerning. If we go back to the slides.
There is a great paper on this. James, tell us about it.
Yeah, so BGUI, so solitary rib lesions, how frequently they're malignant or benign. And the key message here is that it's very, very unlikely metastases. In 2% of the time with gallium, we did find malignancy within those. And so 98% of those were actually benign. And if we looked, and the median of the false positives was SUV max of 3. So it's quite low. Quite similar to this case where when you have that SUV max around 2 and 3, solitary rib lesion, it's very probably benign.
And can I actually make a point here? I think from my learning experience over the years, so 5 years ago, I would have definitely been much more suspicious of that, saying that, likely solitary metastasis, but obviously repeat it again and see whether it's progressed. But these days, right, I would completely actually go more towards the benign side of things, because we know how uncommon it is to actually have a solitary rib metastasis. I mean, we knew that from the bone scan days as well, where a solitary rib lesion as well was very unlikely to be a solitary rib metastasis. So I guess, that really tells us how important having the follow-up is for these patients, and also time when we actually learn in terms of a new technology that comes into place, where we need to know the pitfalls again of what we are seeing and what we're reporting.
Yeah, I agree completely.
I think part of the problem was PSA was so high. That always is that it causes a bit of discomfort. But
Sure.
when a young patient, when it's equivocal like that, you would give him the benefit of the doubt.
Correct.
Lucky last case. We're going to move on to an experimental PET indication.
That's right. So this is a 53-year-old with a PSA of 8, family history of prostate cancer in the father and the brother. The PSA density was 0.2.
What does that mean?
I don't know. You mean doubling time?
Oh, PSA density. No, so it's the PSA divided by the prostate volume on the MR. So it just means that he had a higher concentration of PSA. So it is a red flag clinically. It raises suspicion that with a normal MRI, rings a bell, there may actually be cancer that's hiding there.
It's just some people
And
have
pirates.
100 cc prostates with a PSA 5, and
Right.
Yeah.
in the context of such a large prostate, that PSA is less significant.
Yep. And the pirates was only 2. So I guess the question is, how would you manage this patient? Surveillance, biopsy, or other? But we'll have a look at the scan first, actually, James, if we could.
All right, this is so obviously this is a patient from primary 1. So it's a pelvic only scan, PSMA PET scan. It's with gallium PSMA 11, and it's a beautiful case. You can see here it's quite clear. There is an obvious focus right here. So within the left transition zone, SUV max of 12. So it is quite high. And then you have, you can notice that there's a little bit of diffuse uptake within the rest of the transition zone. So it's quite mild. If you have a look at the MIP right here, you see the bladder here. There's a little bit of diffuse uptake here, which isn't really concerning. And then that focus that is very suspicious. This this is a great example, I find, because you do see the peripheral zone around. Obviously, with low-dose CT, you don't have the resolution of MRI to actually see peripheral zone. But this is a nice PSMA-guided one where you don't see anything that stands out. So this patient did go on to have biopsy, as all the patients in primary, and these are the two patterns. So two patterns. Nathan Papa is actually here, so shout out to him. He did lots of work on the patterns with Louise Emmett, recently published. And
won the best
so this
paper.
Great. So this was off from the best paper. So it is. We will be reading primary 2 cases with these patterns. So here you have a primary. You have a score. A score 2, which is just that diffuse uptake in the transition zone. And this actually would be a 5. So you have an SUV max above 12 in the transition zone.
Take us back to the slides. I think we've got a slide on this just to. We might just go to the primary score. Take us through this slide.
Yeah, so you can see, actually this patient did have prostate cancer, so it was grade group 3. You can see the slide, the different patterns that have been developed, and to the left, those are the benign or the low risk of having cancer patterns. So if there's nothing, as you can see for score 1, nothing that stands out, very mild uptake, we consider that's no pattern, it's very low grade. Score 2 is divided into 2 different parts. So you have pattern A, which is that diffuse transition zone uptake, very homogeneous, nothing stands out either, so we can be relatively comfortable that there's nothing. And the central zone activity, so pattern B, just the bottom left, you see those 2 little spots where the central zone is, very symmetrical. We frequently saw that in the primary cohort. And then if you go to the right, in red, you have those malignant patterns, so focal uptake within the transition zone for 3, anything that's focal within the peripheral zone without defining any minimal uptake with SUV max, so anything that stands out is suspicious and should go on to have biopsy. And finally, score 5 is anything, regardless, with SUV max above 12 that had a 100% probability of having prostate cancer.
So we've learned from our radiology colleagues with multiparametric MRI that differentiating the peripheral zone from the rest of the prostate is really important because most prostate tumours arise in the peripheral zone. So if you have focal uptake in the peripheral zone, even if it's lowish grade, we should be reporting that as malignant. And if it's really intense in the peripheral zone, then it's a score 5. It's almost certainly malignant. So that's the way we're interpreting the prostate now. It's not just the intensity of uptake, but where is it? And if it's just diffuse throughout the gland and it's not in the peripheral zone, we report that as score 2, and that's benign. So I think that's all we have time for.
It is indeed. So thank you all, our panelists today. Declan over there, Louise that did a double shift, Shankar, James that actually put all these slides together,
Thank you, James.
I think you can all. He deserves a huge round of applause because that took an amazing amount of time.
And thank you to Liz also, who helped out.
Yep.
Liz.
There you go.
Thank you. Renew, and then obviously Genevieve as well. So thank you all. Thank you to panel, the audience, both online and here. And now back to you, Annette.
Thank you, everybody. Well, we've got through our second session really successfully. Thank you for all being involved. And thank you to Michael and Z-Team for leading the charge so well. It's now time for lunch. It's all ready to go. For our virtual delegates, please take this on an opportunity to stand up, stretch your legs, get some fresh air because we need you back here after lunch as well. So grab yourselves a coffee and relax. Now, we are going to be back with the third session at about 1:30. We're going to herd you all back in. And we also have a group photo planned. So if everyone, Chris, remind me what you want me to do. Everybody outside into the foyer, and Chris will lead everyone. We'd probably like our ProsTIC team to be at the front of the photo together with Professor Dolan, and we will get that shot so we can tweet that out to everyone. Don't forget to use the hashtag, and we're going to see you all back here shortly. Thank you.